Nikhil, I've sent it on your WhatsApp.
Okay.
You can take it from there.
Mhm. Got it.
It's gone from mine end to your
You
WhatsApp.
got it. I got it. Thank you.
Hmm.
None of the experts have joined as such, I think.
कहाँ पे? I can't see here.
Participants में ही होंगे ना सारे. अभी तो
I
कोई
can see
भी-
only 4 of us over here.
हाँ.
Nikhil, can you see the audience at your end? If some of the moderators have joined by mistake from there. Hello. Hi.
Dr. Seema, I just have one question.
Yeah.
Do you have a slide or a PPT for the introduction, or is it's just going to be a verbal introduction?
No, it is. We have 5 slides of all the CVs of the model experts that we have today.
Okay, fine. So, doctor, right after the disclaimer, there's going to be an introduction video,
Okay.
and there's going to be a disclaimer PPT, so a disclaimer slide.
Okay.
So right after that, you could start sharing your screen and start with the introduction of speakers and the moderators. And then you
Nikhil,
could, yeah.
our moderators are not able to join. Dr. Jyoti
What?
Bhaskar is not able to join.
They could just use the Zoom ID, the meeting ID that you shared, and the password, and they
वो
should
तो
be able
मैंने
to
दिया
join.
है, but she's not able to join.
Okay. Well, Dr. Jyoti Bhaskar and Dr. Leela.
Dr. Jyoti Bhaskar.
One second. She is yes, doctor.
Jyoti is calling you. She's not able to log in.
Okay, not got a message yet. Let me try. 1 second, doctor.
सीमा और मैं तो आ गए। हमारे तो जूम का वो प्रोफाइल बना हुआ है ना, तो डायरेक्टली लिंक पे क्लिक करते ही हमारा तो उसके अंदर हो गया, ना पासवर्ड मांगा ना कुछ मांगा। तुम लोगों ने जूम की नहीं बनाई होगी। हाँ हाँ, तो मैम का भी मैं ईमेल आईडी निखिल को भेजती हूँ। हेलो, ठीक है, मैं निखिल को बोलती हूँ। निखिल,
Yes, doctor.
निखिल कोई भी ज्वाइन नहीं कर पा रहा है। डॉक्टर शारदा जैन का भी फोन आ रहा है, वो भी नहीं ज्वाइन कर पा रही है।
Okay, just give me an issue. Just give me a minute, doctor. I'm just checking on this issue right now.
मैंने भी उनका ईमेल आईडी आपको भेज दिया।
I got that. I've received the email. Just 1 second, doctor. I'm just checking with my tech team. Just give me a minute. So, Dr. Meenakshi, does both Dr. Sharda Jain and does Dr. Leena, so both, do they both have a Zoom account?
नो, आई डोंट नो। डॉक्टर बाकी सारे तो जूम मीटिंग अटेंड करते हैं। आई डोंट नो हाउ दे अटेंड। डॉक्टर शारदा जैन भी नहीं ज्वाइन कर पा रही है। मालती का फोन आ रहा है, मालती भी नहीं ज्वाइन कर पा रही है।
Yeah,
हेलो,
Malti just called me.
नहीं कोई नहीं ज्वाइन हुआ। मैं और सीमा ही है इसमें मीटिंग में। हम्म। निखिल प्लीज डू समथिंग ना, कोई भी नहीं ज्वाइन कर पा
Yeah,
रहा है।
yeah, we're just working on that right now. From our end, it's showing all clear. That's good. I'll just try logging in from a different ID. Just give me a second.
जूम पे तो रेगुलरली होती रहती है मीटिंग सबकी।
हेलो, हाँ जी मैम। Dr. Nikhil, you have 5 minutes. Otherwise, we will have to join from another link, जो हमारा Google Meet का link है. Nikhil?
Yes, Dr. Meenakshi. We're just working on this. I'm just speaking to Dr. Leena right now. We're just trying to get her.
What it is taking, ma'am?
Nobody is able to join.
निखिल ऐसे ज्वाइन नहीं कर पा रहे हैं, हमें ऑल्टरनेट कुछ सोचना पड़ेगा. डॉक्टर शारदा मैम ज्वाइन हो पाई क्या?
So, Doctor, I've just been talking to Dr. Leena right now, and speaking to Dr. Sharda Jain as well. The reason why they were not being able to join is because they didn't have a Zoom account. So we've asked Dr. Leena to create a Zoom account in order to join a Zoom meeting.
तो डॉक्टर शारदा मैम कैसे कर पाएंगी?
I'm just trying to figure that out, Doctor. Just give me 1 second.
The Zoom account almost everybody has because we have so many Zoom meetings nowadays. We don't have any problem any other time.
This what, Doctor? Just give me 1 second, Doctor. I'll just quickly figure this out.
निखिल?
Yes, Dr. Meenakshi. Just
Dr. Jyoti Bhaskar is in the attendees list. Can you
Okay.
promote her to the monitor list? If you
Just
can
one
do
second,
that, then we can promote other people.
okay, 1 second. I'll just check that. I'll just check that.
Dr. Jyoti Bhaskar. Just check if she can be promoted to monitor's link. Hmm.
Good
Hello?
afternoon, Dr. Dina. Unmute, Sam.
Hello.
Hello.
Yeah, I was having a little difficulty getting on my
Yeah.
laptop.
Almost everybody is having difficulty today. I don't know why.
I don't know, something is coming, and even in this, when I did it on my mobile, it took a little while. Otherwise,
Okay.
Zoom is a very
Very
comfortable
easy,
platform,
very easy platform.
So I'm just
Welcome,
calling
ma'am.
that.
Welcome, Dina ma'am. Just
well,
trying to get
hi,
in touch with
Meenakshi,
Jyoti.
yeah, yeah.
Ma'am, Dr. Sharda ma'am also not able to join through the link. There's some trouble during that joining.
That's what I was very
How are
surprised.
you able to join, ma'am, finally?
No, I did it on the mobile, but I'm just waiting. I'm going to try on the Zoom, because we also have Zoom here, you know. So it should have been actually very easy to get on, but I'm surprised.
Yes, even I'm surprised. I didn't have any problem. I just clicked on the link and I joined straight away.
She's
So
telling me download the Zoom app. So I couldn't.
Yes, I'm joining through the Zoom app on laptop.
Okay, so I'm doing that also. That's what has come, that Zoom app download for laptop.
Download that.
Okay. Okay, so
निखिल, आप डॉक्टर ज्योति भास्कर को उसमें लेकर आए क्या मॉडरेटर उसमें पैनल में? Nikhil?
Yes, Dr. Meenakshi. Okay. Okay, so Dr. Meenakshi, so I was just having a word with Dr. Sharda Ji. So she was, so she was having an issue with logging in again. So
we are all having, Nikhil, we are all having.
So I'm not entirely sure why this problem is happening, doctor, at the moment. So, but if you want, we could carry on with
what is happening. It's coming to, you know, the attendees thing, and then it is showing a mail and a password. So the problem is we don't know which. So we are putting in our own mail ID, no?
Yeah, you should add
your
passcode.
And for the passcode, it's not very clear which, because the passcode is the one which you have sent us, the Doc Pro. If you put that, it's not coming.
Okay. So, doctor, so we could do one thing. I just spoke to Dr. Sharda Ji. She said if we could just continue the meeting, go ahead with the meeting since Dr. Meenakshi and Dr. Seema is here. So, I think Dr. Shashi Kabra and Dr. Sharda Ji is missing, right?
Dr. Shashi Kabra also.
IT की problem हो रही थी.
But we won't be able to have an interaction. How will the experts give their opinion? Not able to join.
We can't have a meeting like this.
Yes, definitely.
Yeah, good afternoon.
So, I mean, Dr. Sharda Ji would be joining hopefully in the next 2 minutes. We're in talks with you. We're just trying to give her the access, trying to walk her through the entire process. Still
not been able to connect on the laptop.
So, doctor, I believe the issue that is happening is where when you enter your email ID, right? Over there, you have to give your email, your password. So the Doc Pro, that password is basically for the meeting ID and the password. The Doc Pro is the password for the meeting
Okay.
ID. So there's two options when you open Zoom. One is join meeting, one is sign up or login. So if you press join meeting,
That's what I did. No, I did from Google. I went on from Google to Zoom. You can do that also.
yeah, which one? So over there, there'll be options called join or sign up.
Why is it happening like that? Because see, it used to be so easy. You used to go into Zoom and the meeting and the password comes in, Like I'm going
The
into
meeting ID and the password, exactly.
yeah, Zoom video communications is coming. So, है ना?
निखिल, डॉक्टर शारदा मैम आई थिंक अटेंडेंस लिस्ट में ज्वाइन किया है मैम ने.
No,
आप उनको
we are
अपग्रेड भी नहीं कर
on
पा
call
रहे हो
with
क्या?
we are on call with Dr. Shada Ji. We're trying to get her into
नहीं,
this
who
link.
is the Doc Pro events host? Are you handling that handle?
There's going to be me and we have a events team also.
हाँ, तो इवेंट्स टीम जो होस्ट जिसके अकाउंट से है, that person can upgrade the people who are in the attendee list.
No, not exactly, doctor, because they are attending to the website. They're joining from the website and they're watching the entire Zoom through the website. We're just hosting it on Zoom, but
Browser.
yeah, there's a microsite created for this, so they'll be watching it from there.
Nikhil, then we can't have the meeting like this.
Very complicated today.
Yes, doctor, I understand that this been a
Then
small.
we have to then reschedule it. We can't have it like this. Half our moderators are not able to join.
Without the moderators, without the experts, it's of no use at all.
I completely agree, doctor. That is what. So we are right now, as we are speaking, only we are with talks with Dr. Shada Jain. We are trying to get Dr. Shada Jain, Dr. Shashi Kabra, and Dr. Jyoti Bhaskar.
Dr.
Yes.
Leena is also, I think.
She has dropped off. She has also
Yeah,
dropped
she's
off.
also left.
Nikhil, Nikhil, I think we should start with this meeting. Okay. Dr. Seema,
Yes.
unmute yourself.
And
Dr. Seema, you please start the meeting.
so
Okay, we'll
without
just go ahead with the meeting, have a talk. Huh? By the time, I think Nikhil will be able to find a way out.
Yeah, Dr. Meenakshi, just 1 second. So I'm just for everyone's listening here
Until
on.
3:20.
Yes, doctor, I could see that. So doctor, the issue was so one second. So doctor, first before I say anything else, we are on live, so the attendees are being able to listen to our conversation. So can you all go on mute and we'll have this conversation. I'll just give you a call. Yeah, so hi, Dr. Meenakshi, Dr. Seema. We are going to be going live right now.
Yes, Nikhil.
Okay.
good afternoon, everybody. Welcome all to this meeting on a very important topic, postpartum hemorrhage, a deadly complication for all the obstetricians. We have Dr. Meenakshi speaking on the role of oxytocin in management of postpartum hemorrhage. I think, Nikhil, will you show the video first? Nikhil,
Yes, Dr. Seema.
are you showing the video first?
Yeah, we just got to start with the introduction slides, and then you could, once the disclaimer is done, you could start with introduction, and then you could start with
Carry on with your.
Okay.
Yes, Dr. Seema. You
Yeah,
start.
yeah, starting.
Go to your tab, Google Slides, center tab.
So today's topic is role of oxytocin in treatment of PPH. And the speaker for today's topic is Dr. Meenakshi Sharma. We have our experts, Dr. Shadda Jain ma'am. She's the founder secretary of the Delhi Gynae Forum, the pillar of Delhi Gynae Forum. We have Dr. Jyoti Bhaskar. She's the principal consultant obstetrician and gynecologist at Apollo Federal Hospital. And she's currently the president of Delhi Gynae Forum East, a great academician. Then we have Dr. Shashilata Kabra Maheshwari ma'am. She is the specialist at DDU Hospital, ND faculty, a recipient of many awards, and a champion of PPH training. We have Dr. Leena Sridhar ma'am. She is a senior consultant obstetrics and gynecology at Manipal Hospital, Dwarka. She has received many awards to her, and she's a great teacher. I welcome all our experts. And the speaker is Dr. Meenakshi Sharma. I request Dr. Jyoti, she is the consultant obstetrics and gynae at Yashoda Hospital. She has received many awards. Welcome, Dr. Meenakshi. Please start your presentation.
Thank you, Dr. Seema. And I'm extremely sorry regarding the technical glitches, so that many of our moderators are still in the process of joining in the meeting in the moderator panel. Meanwhile, I'll be starting my talk, which is on postpartum hemorrhage, role of oxytocin in the treatment. Postpartum hemorrhage, as we all know, is defined as a blood loss of 500 ml or more following childbirth. And it leads to about almost 27% of global maternal death worldwide, and almost affects 5% of the live birth. This is according to the latest WHO 2020 bulletin. FIGO has taken cognizance of the effect of the hemorrhage, which is the leading direct cause of maternal death. Almost 27% of the maternal deaths and more than two-thirds of the reported hemorrhage deaths are due to postpartum hemorrhage. We all know that the causes of postpartum hemorrhage are due to atonia of uterus, uterine rupture, retained placental tissue, genital tract trauma, and maternal coagulation disorders. There are various risk factors for postpartum hemorrhage. It can be an antepartum hemorrhage, which can be associated, or the labor which has been augmented along with an hyperstimulated uterus, chorioamnitis, fetal macrosomia, maternal anemia, maternal obesity, multifetal gestation, preeclampsia, and primiparity, as well as the prolonged labor. All these are the risk factors for postpartum hemorrhage, and we need to be careful for monitoring these patients while they are in labor. Oxytocin is the primary oxytocin used to prevent and treat atonic PPH. Oxytocin, as we all know, it's a nonapeptide which is found in the pituitary glands of all mammals. It causes uterine motility, depends on the formation of the contractile protein actomycin under the influence of calcium channel dependent phosphorylating enzyme myosin light chain kinase. Oxytocin promotes contraction by increasing the intracellular calcium, which leads to the spiral muscles of the uterine musculature contracting the uterus, leading to the blood vessels which gets constricted, and the blood flow after the delivery as in postpartum hemorrhage gets controlled. So they are the oxytocin receptors which are present in the myometrium, and the concentration of these oxytocin receptors increases as is seen maximum in early labor near term. So oxytocin, even in its pure form, has some inherent pressor and antidiuretic properties, which are due to structural similarity to vasopressin. And the half-life of oxytocin is only 1 to 6 minutes. It's rapidly cleared off. The oxytocin basically can be given by intravenous route or intramuscular route. Intravenous route causes the action to be started immediately, and the duration of action lasts almost for 1 hour after an IV dose of oxytocin being administered. Intramuscular oxytocin, the onset of action starts within 3 to 5 minutes, and the duration of action lasts 2 to 3 hours. And the oxytocin is primarily removed from the plasma, from the circulation of the mother by kidneys as well as by liver. The dose of oxytocin which have been used for prevention and treatment of PPH is varied. And for the prevention, it is used as a 10 units of IM or 5 to 10 units IV bolus is given for prevention of PPH. While when the patient is having PPH and we need to treat them, then we have to give the higher doses like 20 to 40 international units in 1 liter of normal saline, and that solution is infused over 10 minutes, and then gradually over 250 ml is infused for further another hour. The mechanism of action, as I've already told, it stimulates the upper segment of the myometrium to contract rhythmically, and it constricts the spiral arteries and decreases the blood flow through the uterus. The overdose of oxytocin can also cause certain problems. As in antepartum, when we are using it for augmentation of labor, it can cause hyperstimulation, fetal distress, and rarely it can cause rupture of uterus and hypertensive crisis. And a subarachnoid hemorrhage has also been reported. Overdose or in fact prolonged use of oxytocin, especially when it is used over a 24-hour infusion, then it can lead to water intoxication because of its intrinsic antidiuretic effect. Severe water intoxication even can cause convulsions and coma, which has been reported in literature. Possibly, it can also cause hypotension with intravenous use of oxytocin following cesarean delivery, especially when used along with the cyclopropane anesthesia. So, and maternal sinus bradycardia and abnormal atrioventricular rhythm has also been noted, especially when it is used concurrently with cyclopropane anesthesia. There are certain adverse effects in the neonates as well. The following adverse reactions has been noted, which can be the bradycardia, they can be premature ventricular contractions, and other arrhythmias can occur in the neonate. Permanent CNS or brain damage can occur. Fetal death can be caused. And a neonatal seizure has also been reported with the use of oxytocin. Due to the use of oxytocin in the mother, neonates can have low Apgar scores. They can have increased incidence of jaundice, and they can also have a neonatal retinal hemorrhage. Active management of third stage of labor has been actively promoted as an intervention to prevent postpartum hemorrhage.
Some network issue with Dr. Meenakshi. She's joining shortly again. network issues with all. Let's keep some patience.
Hello,
Hello.
can you hear me?
Yes, yes, we can. We can.
And can you see my screen?
No.
Can you see now?
No, no, we can't
No.
see. Well, Meenakshi, we've been trying. No, we're not able to connect
Not
on
able to see
laptop.
your screen.
Can you see my screen?
Yes.
Dr. Seema, can you see my screen?
Yes, yes, we can.
I can't see.
We can see her phone call.
No, the screen is not
Can you see
seen.
now?
Yes. You've logged in from the phone now. Your voice is breaking. Some disturbance in the audio. Disturbance in the audio, Dr. Meenakshi. Audio is not clear, Dr. Meenakshi.
Are you able to see my Are you able to see my screen? डॉक्टर सीमा, आपको मेरा स्क्रीन दिखाई दे रहा है?
Screen दिख रहा है आपका? Voice is cracking in between.
Yeah, now can see the screen.
Screen is there.
Yeah.
Now the screen is gone.
You can see my screen.
No.
Now we can't. आप ट्राई करो, नहीं हो रहा।
साइन इन ही मांग रहे हैं, साइन इन ऑथेंटिकेशन के साइन इन ही मांग रहे हैं। ईमेल आईडी फैच कर रहे थे वो
वो पता नहीं उन्होंने क्या किया, फोन तो आ रहा है।
ज्वाइन एज ए होस्ट नहीं किया होगा ना कि सबको एक्सेप्ट कर सकते हैं।
वही ना, इन्हीं की गड़बड़ है यार, देखो।
इन्होंने जो
हाँ।
क्रिएट किया
You can see the screen, Dr. Meenakshi, now.
Can see the screen?
Yes, yes.
Okay.
Yeah, now it's clear.
I'm so sorry. This net suddenly goes off because of the electricity problem, and then I was not able to log in from a mobile.
Yes. Yeah.
It's okay now.
It's easy to log in, and Zoom, it's very difficult to log in back. I'm extremely sorry. And now I'll just continue from the, I hope where I have left. I think this everyone has heard, or I will start from the active management of third stage of labor. We all know that it has been actively promoted to prevent postpartum hemorrhage. It reduces the risk of postpartum maternal hemoglobin drop less than 9 gram per deciliter and the need for manual removal of placenta along with preventing the postpartum hemorrhage. The component of active management of third stage labor, we all know it is administering any uterotonic, preferably oxytocin, with or soon after the delivery of anterior shoulder, controlled contraction, and a uterine massage after delivery of placenta. This has been a beautiful flow chart given in the ACOG 2017 practice bulletin, where they have shown not only the management of postpartum hemorrhage, but also the causes, the 4 common causes we all know: tone, trauma, tissue, and thrombin, and the respective management in a one single flow chart. Where we know that the 4 common causes of postpartum hemorrhage are tone, trauma, tissue, and thrombin. And for atonic uterus, atonic postpartum hemorrhage.
ऐसे हुआ है, big bosses could not connect. सब कोशिश कर लिया है।
Selina ma'am, please mute yourself.
I know, ma'am. Oxytocin is the first line uterotonic in the management of atonic postpartum hemorrhage, and it is given in the doses of 20 to 40 international units in 1 liter of normal saline. It is infused in a 500 ml over 10 minutes and then 250 ml per hour subsequently. Other uterotonics for management of atonic PPH are also described are prostaglandin, that is a carboprost, 250 microgram intramuscular into the myometrium every 15 to 90 minutes, methergin 0.2 milligram IM every 2 to 4 hours, or Mesoprostol 800 to 1000 microgram rectally, or 600 to 800 microgram sublingually or orally. The second line uterotonics for treatment of PPH, carboprost is a prostaglandin F2 alpha analog. It improves uterine contractility by increasing the number of oxytocin receptors and causes vasoconstriction. The dose I have already described is 250 microgram IM every 15 to 20 minutes for a total dose of 2 milligrams. Contraindicated in patients who are asthmatic or have significant renal, hepatic, or cardiac disease. The adverse effects are nausea, vomiting, and diarrhea. The second line Uterotonics for postpartum hemorrhage, another one is the Methergine, which is given as a 0.2 milligram IM repeated every 2 to 4 hours. It should be avoided in patients who are hypertensive, who have PIH, and even chronic hypertensive should not be given Methergine. The most common adverse effects noted after Methergine are the nausea, vomiting, and high blood pressure. Another Uterotonic for treatment of PPH is the Mesoprostol, which is a prostaglandin even analog. It is given in the dose of 600 microgram orally, or 800 to 1000 microgram rectally, or even up to 800 microgram sublingually can be given to treat postpartum hemorrhage. It should be used for the basically contraindications are in patients with cardiovascular disease, where it should be avoided. And the adverse effects are nausea, vomiting, diarrhea, and especially pyrexia and shivering, which is most commonly seen after use of misoprostol. Tranexamic acid has been promoted for treatment for postpartum hemorrhage by WHO. It is given as a 1 gram IV injection, as it has been seen that it reduces the mortality due to bleeding for postpartum hemorrhage, but not overall mortality. When given within the first 3 hours, so it can be considered as an adjuvant therapy of postpartum hemorrhage, though it is not a neurotonic drug. And there's a champion trial which has come up recently, and it has really changed the management of prevention of postpartum hemorrhage, as it added the drug of carbetocin in postpartum hemorrhage prevention. This champion trial was a big trial. It was conducted almost in 29,000 women and across 10 countries. And even this such large population, it has been noted that only 26% of women with a blood loss between 500 and 600 ml received a uterotonic drug of PPH. And even with a blood loss of 1000 to 1100 ml, only 70% of the women received any uterotonic drug for the treatment of PPH. So postpartum hemorrhage is not being adequately treated by using a uterotonic drug. Maybe the logistic factors, maybe it is the underestimation of the postpartum hemorrhage, but there are many people who are suffering from postpartum hemorrhage fail to receive a uterotonic drug. So we should know that the real world PPH detection rates are very low. In Nigeria, it has been found to be only 2.2%. In Tanzania, 2.5%, and Kenya is very low, 1.8% only. They are able to detect the PPH in such patients. We have a lot of evidence with oxytocin. I will be sharing 3 Cochrane reviews which has been published recently. This was a review which is published in 2019. It was oxytocin to prevent excessive blood loss for women during 3rd stage of labor. So it included 24 trials, and 23 trials out of that contributed to the data, which involved about almost 10,000 women. And it had concluded that the prophylactic oxytocin compared with no uterotonics may reduce the blood loss and need for additional uterotonics. The effect of oxytocin compared to ergot alkaloids is uncertain with regard to blood loss, need for additional uterotonics, and blood transfusion. Another Cochrane review came up in 2020. This was the latest one, which has compared intravenous with intramuscular prophylactic oxytocin for reducing blood loss in the 3rd stage of labor. And it involved 7 trials involving 7,817 women. And they have concluded that intravenous administration of oxytocin is more effective than intramuscular administration in preventing PPH during vaginal birth. Intravenous oxytocin administration presents no evidence of additional safety concern and has comparable side effect profile with its intramuscular administration. Future studies should consider the acceptability, feasibility, and resource use for intervention, especially in low resource settings. So they have observed that IV is definitely better than intramuscular in preventing the PPH during the vaginal birth, but the margin is narrow. So in situations where low resource situations with facilities for IV administration of oxytocin is not available, intramuscular oxytocin should be given. This is another Cochrane review which has been published in 2018. Plutotonic agent prevention of postpartum hemorrhage. It was a network meta-analysis of almost 196 trials, including almost 135,000 women. It is the biggest review of meta-analysis of pph, which has been published, and it has shown that all agents are effective in preventing postpartum hemorrhage more than 500 ml when compared with placebo or not no treatment. So any uterotonic, whatever is available, can be given for prevention of pph. And ergometrin plus oxytocin combination, or carbetocin, or a mesoprostol plus oxytocin combination. These three strategies have some additional desirable effects compared with current standard oxytocin. They have found to be more useful than plain oxytocin alone in preventing pph. The two combination regimes, that is ergometrin plus oxytocin and mesoprostol plus oxytocin, however, associated with significant side effects. So carbetocin may be more effective than oxytocin for some outcomes without an increase in the side effects. But the pph, which is more than 1000 ml, oxytocin as well, along with the mesoprostol combination, or ergometrin plus oxytocin combination and carbetocin, all three prevents postpartum hemorrhage greater than 1 liter. So WHO recommends Uterotonic for postpartum hemorrhage for prevention and says that the oxytocin 10 units IV or IM remains the recommended uterotonic of choice for all births. In settings where oxytocin is not available or its quality cannot be guaranteed, the use of other injectable uterotonics like carbetocin, or if appropriate, ergometrin, ergometrin, or oxytocin and ergometrin fixed dose combinations, or even oral misoprostol is recommended for prevention of pph. So oxytocin 10 units IV or IM is the first line for prevention, and all others come later. So this was a beautiful flow chart which has been published by WHO in 2019 in a British Medical Journal. They have said that if there's a skilled health personnel who is able to administer injectable uterotonic, if it is not available, give misoprostol. If available, then is the cold chain transport and storage facility available? If not available, give a heat stable carbetocin or misoprostol. If the cold chain transport and storage facilities are available and the oxytocin is available, then give oxytocin 10 international units IV or IM. So this is the latest recommendation from WHO. So causes attributing to maternal mortality in postpartum hemorrhage, we all know that anemia which has not been corrected attributes to maternal mortality. Delivery in setups which are not equipped to manage pph, where there is either not trained manpower or drug is not available, then the problem will be there of increased morbidity as well as mortality from pph. Underestimation of blood loss is another very, very important factor, which we all must ensure that we estimate the blood loss correctly. Underestimation can lead to increased morbidity and mortality. Delay in referral as well as improper referral also contributes to mortality of postpartum hemorrhage, especially when we are referring a sick patient to a tertiary care. Delay in surgical procedure for postpartum hemorrhage, compression sutures, devascularization, and hysterectomy, if they are not done in time, then can also lead to postpartum hemorrhage. Delay in registration with blood components is also another factor. So we should estimate blood loss. Visual estimation is very easy to do, but grossly underestimates the blood loss. Calibrated perineal drapes can also be used, as well as we can weigh all mops and drapes. So this is how the perineal collector bag is used. However, there's a mixing with the liquor, and the estimation of the blood may not be proper. So it is better that we estimate the blood loss after delivery of the baby, so that the liquor is drained out, and then we collect any postpartum hemorrhage if it is occurring. This is another flow chart which we can put in our labor room, where we can estimate by the number of mops, like a large 18 by 18 inch 6-ply mop laparotomy sponge. If it is fully soaked, dripping wet, then it contributes to almost 160 ml. So we can count or we can weigh. This is also one table we should all keep plastered in the labor room, that how much blood loss is usually lost whenever we are having different kinds of mops are available, or if 1 kg soaked swabs are there, it contributes to 1 liter of blood loss. A kidney dish full of clots is almost 500 ml. 50 centimeter diameter floor spill is almost 500 ml blood loss. 75 centimeter is almost 1000 ml. A 100 centimeter diameter floor spill is 1500 ml blood loss. Vaginal ppH, which is limited to bed only, may be less than 1 liter. But if it is spilling over the bed from the floor, then it is usually more than 1 liter. We must assess maternal hemodynamic status correctly. Vitals is of very, very importance that we need to be assessing them properly. Monitoring of pulse rate, BP, respiratory rate is very important. So if we feel that systolic blood pressure has fallen to less than 80 and is associated with worsening tachycardia, tachypnea, altered mental status, and it indicates a postpartum hemorrhage of more than 1500 ml. Rule of 30 is also very, very important that we must all keep in mind. Any fall of systolic blood pressure more than 30, pulse rate increase by 30 beats per minute, urine output which is less than 30 ml per hour, hematocrit less than 30, it almost amounts to blood loss which is more than 30% of whole blood volume. So these patients should be actively resuscitated with blood components, and if they are bleeding actively at this point, all measures should be taken to control bleeding. Shock index is very useful, very simple. We all should know. Pulse rate, if they are more than systolic blood pressure, it shows that the patient is in shock. So massive transmission protocol needs to be activated whenever there is a systolic blood pressure which is falling to less than 90. When there is a acidosis like pH is less than 7.1, base deficit which is more than 6 milliequivalents per liter, temperature it is below 34, INR, PT-INR more than 2, or a platelet count less than 50, and a patient is actively bleeding, a massive transfusion protocol should be activated. Blood bank should be ordered to issue 6 units of packed RBCs, FFP, platelets, and 10 units of cryoprecipitate in such a situation. So FIGO has recently proposed a Pph bundle. I want everyone to know this, that postpartum hemorrhage care bundles should be adhered to so that we have a better maternal outcome, and postpartum hemorrhage maternal deaths can be prevented. So this is a literature which is available on the website freely. Anyone can go and listen to the whole about Pph bundle. FIGO depends that Pph should be prevented as well as treated in a bundle approach. What is it? It's like a Pph emergency response, which is the hardcore modality for controlling the postpartum hemorrhage, along with other facility readiness, network integration, teamwork communication, respectful maternity care, data monitoring, quality improvement, and leadership. The Pph emergency response by managing by Pph bundle is the core of this Pph emergency care. So what is a Pph care bundle? It's a clinical care bundle, set of discrete evidence-based interventions administered concurrently or in rapid succession to every eligible person, along with teamwork, communication, and cooperation. Once triggered, all bundle components must be delivered. So whenever these are triggered, trigger is patient actively bleeding, the whole bundle should be activated. All the components of that particular bundle should be delivered to prevent postpartum hemorrhage. What makes a bundle so special? Why a bundle approach is given? It is because the power of the bundle comes from the body of science behind it and the method of execution with complete consistency. It's not that the changes in the bundle are new, they are well-established best practices, but they're often not performed uniformly, making treatment unreliable and at times idiosyncratic. So bundle ties the changes together into a package of interventions that people know must be followed for every patient every single time. So this is the Pph bundle. It has many components, like an active management of third stage labor is for prevention. If a patient is actively bleeding, one should call for help. Then there's a first response bundle. Then there's a response to refractive Pph bundle. So active management of third stage labor involves 3 components: uterotonic drugs, bimanual massage, controlled contraction. And if the patient is actively bleeding, we must call for help. Here comes the importance of estimation of the blood loss. We should never underestimate blood loss. In fact, we should act as if the patient is actively bleeding, and we must overestimate the blood loss rather than underestimating the blood. Postpartum hemorrhage, this is the first response bundle. When a patient is bleeding actively after AMT-ACL has already been done, but the patient is bleeding, then all the 4 components should be started simultaneously. It includes a uterine massage, uterotonic medications, which I have already described, IV fluids rapidly to resuscitate the hemodynamic component, and giving a tranexamic acid. This is the first response bundle which should be given to any patient who is bleeding actively following an active management of 3rd stage of labor. Along with the supportive measures like check for tears and repair, remove the placenta, empty the bladder. And this is another emotive bundle, which is basically nothing but a first response bundle only. It's the early PPH detection using a calibrated drape, uterine massage, oxytocin drug, tranexamic acid, IV fluids, and genital tract examination and escalation whenever necessary. This is the first response PPH bundle only, with the nice name given to it, emotive. When, despite these measures, the initial first response PPH bundle, despite all these measures, patient is actively bleeding, it amounts to refractive PPH, and it involves further interventions which has been bundled together in a refractory PPH bundle that involves compression maneuvers, bimanual compression or abdominal aortic compression, or uterine balloon tamponade or non-pneumatic anti-shock garment. This is basically for facilities where we need to transfer the patient to a tertiary care. So all these components should be kept in mind. Everyone in the labor room should be knowing how to do a compression maneuvers like a bimanual compression or an abdominal aortic compression, how to put a uterine balloon tamponade, and if the NSG is available, then it should be promptly instituted. So the response to refractive PPH bundles are the compressive measures like aortic compression or bimanual uterine compression, intrauterine balloon tamponade, and non-pneumatic anti-shock garment. So these are the components which we need to have a evidence-based training with stimulation and teamwork and communication. Each and every labor room, wherever all the facilities where deliveries are taking place, all the personnel involved in the maternal care should be taught these 3 responses to refractory PPH bundle. Along with the supportive measures, blood transfusion, and a transport to higher care if needed. Additional best practice has also been given, like a PPH prevention. We should correct anemia. Prior to that, we should birth planning and complication preparedness. We should be ready for high-risk pregnancies. We should refer them in proper places where such patients can be taken care of. First response is very important. Early recognition of excessive bleeding. We must monitor vital signs simultaneously. Laboratory testing should be done. And the placenta, whether it was delivered completely or whether it is retained, should be determined. And a woman should be reassured, and a family, that everything is already being done. We must communicate to the relatives also. Response to refractory PPH, we must inform women and her family of treatment options, provide reassurance, continue monitoring the status and development of shock. If shock is suspected, begin shock management, transfuse blood products, transfer it if appropriate, and surgical management if the facilities are available, that should be prompted given, like a uterine compression sutures, uterine utero-ovarian artery ligation. We should begin with the conservative management, try to spare uterus, but mother's life comes first. Uterus can be spared. We can resort to hysterectomy earlier rather than having a uterus and a patient dying. So we must resort to early hysterectomy to prevent bleeding and maternal mortality. So this is today's presentation. I conclude, and I'll just stop sharing. And
Thank you, Dr. Meenakshi. Thank you so much. I'm deliberating on such important topic. It needs revision every day for all of us, all the obstetricians. Due to the technical glitches, we could not have all our experts on board. We would be missing the expert comments from them. We have Dr. Leena Sridhar ma'am. I request her to please give her comments and conclude the session. Unmute,
Ma'am, you're
ma'am.
muted.
Unmute.
Yeah, so it was a very informative talk, Dr. Meenakshi. You covered up, I think, management of PPH in a real, very short period of time in a nutshell. I especially liked what you had to say about, the Pph bundle, and especially about how to manage the refractory PPH. As far as the NSG garment is concerned, I've started procuring it. It's now not only just for, when you want to transfer the patient to a higher center, but even in centers like ours, what happens is, like when you have PPH and there is a waiting for taking the patient into the theater. So this is I think a wonderful method which we all can keep and teach our, junior and residents who are there, how to ensure that the patient doesn't go into hypovolemic shock. Even traumatic PPH, you can do it and then take her just like that to the theater as and when you get the theater, because sometimes it happens that there is a delay. And so that is again one thing I feel, even in centers like ours, we can use the NASG garment. And the other methods that you mentioned, what I feel is that we should most importantly conduct regularly the PPH drills. I think that is the most important thing, because centers which have everything, what happens is there's always a turnover of the residents who come in. The older ones leave and the younger ones come. So this is something which has to be like an ongoing training. It's quite the basis of obstetrics in any hospital. So we need to ensure that they're aware of the, how to look after the patient and how to take care of PPH in a hospital setting, if you are in a hospital setting. And of course, those who are in smaller centers can, sort of understand what are the measures that they can use. While the topic we were to highlight upon oxytocin, I think it was wonderful, because still in all the centers, oxytocin is the, you could say, the backbone of our management of PPH. And the other things are also now being used, but primarily, and even WHO says that, the oxytocin should be your first line, both in prophylaxis as well as in treatment of PPH.
The most important thing which I went through while preparing for this talk, that in the champion trial, where it was a non-inferiority trial of a carbetocin versus oxytocin, they have seen that even 26 to 30% patients did not receive any uterotonic drug, and they were having a blood loss of more than 500 ml. So I think active management of third stage labor should be universally applied to all patients. If it can be given in time, then postpartum hemorrhage can be prevented to a large extent. And the second thing, most important thing, which everyone should know, that we always underestimate blood loss. We should, everyone should know rule of 30, a shock index. Whenever the patient is bleeding, any tachycardia, a fall of blood pressure, even by 20 millimeters systolic blood pressure should trigger you that this patient is bleeding. And the bundled approach of first response bundle approach should be taught to each and everyone. I think with this, the earlier we can control the bleeding, we can save many mothers from dying from PPH. Because once the blood loss is more than 1500 ml, then the whole course goes downhill, and the mothers is difficult. They have very high morbidity and mortality, and it's really difficult to save them.
I would just add one more thing. When you mentioned about tachycardia and the shock index, once with all your conservative methods, whether it's medical or whether it's with the balloon, you find that there is the patient has gone, has had her blood pressures have fallen, then one should understand that even if you are able to, with crystalloids, able to bring her blood pressure up, you've already gone beyond 1500 ml, and therefore you must take definitive treatment. And one should not hesitate to do a hysterectomy if that may be. Let's not postpone it, because like if you remember that there was this discussion about losses, maternity losses, and they found in the confidential inquiries, they found it was always because of too little being done too late. That was the reason why mothers were lost. So we have to do this like, it's like a continuum. The Pph bundle should not be that you're waiting for the first one to get all right and then you go to the next step. It should be in a continuum.
That is the main importance of having a bundle approach, that just one trigger, patient is bleeding, all 4 things should be done simultaneously. So that you control the bleeding then and there, and just don't let the patient go downhill the course of having a PPH morbidity and mortality. So that's the way the bundle approach should be taught, I think, to everyone. And I really like that.
Thank you, Dr.
Thank you, Dr. Leena ma'am, for being there with us today.
Talk, Meenakshi, yeah, despite the difficulties, at least we could hear your talk clearly and understand that.
Yes, ma'am. In between, the light also goes as if everything has to go wrong the same day.
Sometimes this happens. I think these are the challenges of the IT world. You feel so helpless because you are not able to connect.
Yes, ma'am. I was feeling so helpless when the light goes off. Normally, I present with my mobile if the thing goes off. I was trying from a mobile, but with mobile, Google Meet is easy. Going to Zoom and this particular link, it was getting so difficult that I was not able to present from my mobile. Then again, somehow the light came and I can get through on the laptop. So I'm really sorry for that.
That's all right. That's all right.
Thank you so
wonderful
much.
talk, and we really thoroughly enjoyed hearing you, and you covered it up so beautifully. Very nice.
Thank you, ma'am. Thank you so much. Thank you so much.
I think we can get the recording and share with others who could not join today.
Yes, we can share the recording. Yeah.
Thank you all. Thank you for all the attendees, and sorry for whatever technical glitches, and we could not have our experts on board to give their expert comments. Thank you so much. I think we can continue.
Thank you, ma'am.
Bye.
Thank you, ma'am. Bye, ma'am. Okay, Nikhil, over to you now.
That's it, Dr. Meenakshi. Thanks a lot for joining. Thank you, Dr. Seema. Thank you, Dr. Leena.
Thank you.
And yeah, that's pretty much it.
Okay, thank you.
Thank you, doctor. It was great having you all on board.
Yeah, thank you so much. Bye-bye. Signing off.